QT interval is the time from the start of the Q wave to the end of the T wave. It represents the time taken for the ventricular depolarization and repolarization. As it starts from the Q wave represents the ventricular septal depolarization. R wave represents the major ventricular depolarization. S wave represents the basal part of the ventricular depolarization. ST segment represent the end of the depolarization and the starting of the repolarization, and T wave represent the ventricular repolarization. Thus, it represents effectively the period of ventricular systole from ventricular isovolumetric contraction to isovolumetric relaxation. The QT interval is inversely proportional to the heart rate. QT interval shortens when there is faster heart rate, and QT interval lengthens when there is slower heart rate. How to measure the QT interval? The QT interval is usually measured in either lead 2 or V56. However, the lead with the longest measurement should be used. Several successive bits should be measured. Large U waves more than 1 mm that are fused with the T wave should be included in the measurement. Smaller U waves are those that are separate from the T wave should be excluded. The maximum slope intercept method is used to define the end of the T wave. As we can see from the diagram, on the left and the middle side, there is smaller U waves and those are separate from the T wave. Thus, this should be excluded from the measurement. On the right side, the large U wave that are fused with the T wave, thus this should be included in the measurement. The QT interval is defined from the beginning of the QRS complex to the end of the T wave. We can easily find out the end point of the T wave by drawing a tangent line from the maximum slope of the T wave. In the picture, it is shown as a red line. And this tangent line, where it intersects with the isoelectric line, in the picture, it is shown as black dots. So the intersection between this isoelectric line and the tangent line that drawn from the maximum slope of the T wave, this intersection point, which is shown in the picture as a blue line, is the end point of the T wave. When the notched T waves are present, the QT interval is measured from the beginning of the QRS complex to the intersect point between the isoelectric line and the tangent drawn from the maximum slope of the second notch. Corrected QT interval. The corrected QT interval estimates the QT interval at a standard heart rate of 60 beats per minute. This allows comparison of the QT values over time at different heart rates and improves detection of the patient at increased risk of arrhythmia. There are multiple formulas used to estimate corrected QT interval. It is not clear which formula is most useful. Bazet formula, where the QTC equals to QT divided by root of RR. That means the RR interval in second. In this diagram, we can see RR interval is about 24.5 small square. QT interval is 13 small square. As we know, the duration of each small square is 0.04 second. So the QT interval will be 13 into 0.04, that is 0.52 second. RR interval will be 24.5 into 0.04, so 0.98 second. So the corrected QT will be QT by root of RR, that equals to 0.52 by root of 0.98. Root of 0.98 is 0.989. Therefore, the corrected QT interval will be 0.53 second. Friederichia formula, QTC equals to QT divided by RR to the power 1/3. Framingham formula, QTC equals to QT plus 0.154 into 1 minus RR. Hogg's formula is the QTC equals to QT plus 1.75 into heart rate minus 60. Fortunately, there are now multiple phone apps that will calculate the corrected QT interval. For example, mdcalc.com has a quick and the easy QTC calculator that is free to use. Normal QTC values are: QTC is prolonged if more than 440 millisecond in men or more than 460 millisecond in women. QTC more than 500 is associated with an increased risk of Torsades de Pointes. QTC is abnormally shortened if it is less than 350 millisecond. A useful rule of thumb that normal QT is less than half of the preceding RR interval. Causes of prolonged QTC are hypokalemia, hypomagnesemia, hypocalcemia, hypothermia, myocardial ischemia, return of spontaneous circulation after post-cardiac arrest, raised intracranial pressure, congenital long QT syndrome, and some medication and drugs. Hypokalemia causes apparent QTC prolongation in limb leads due to TU fusion with prominent U waves in the precordial leads. Hypocalcemia typically prolongs the ST segment, leaving the T waves unchanged. Severe hypothermia can cause marked QTC prolongation, often is associated with bradyarrhythmias, especially slow AF, Osborn waves, and the shivering artifact. Myocardial ischemia tends to produce a modest increase in the QTC in the range of 450 to 500. This may be useful in distinguishing hyperacute MI from benign early repolarization. Both may produce similar hyperacute TU waves, but benign early repolarization will usually have a normal QTC. A sudden rise in the intracranial pressure due to subarachnoid hemorrhage may produce characteristic T wave changes, cerebral T waves, that is widespread deep T wave inversion with a prolonged QT interval. There are several congenital disorders of ion channels that produces a long QT syndrome and are associated with increased risk of Torsades de Pointes and sudden cardiac death. Causes of short QTC are hyperkalemia, congenital short QT syndrome, and digoxin toxicity. Hypercalcemia leads to shortening of ST segment and may be associated with the appearance of Osborn waves. Congenital short QT syndrome is an autosomal dominant inherited disorders of potassium channels associated with an increased risk of paroxysmal atrial and ventricular fibrillation and sudden cardiac death. The main ECG changes are very short QTC, that is less than 300 or 350 millisecond, with tall peaked T waves. Short QT syndrome may be suggested by presence of atrial fibrillation in young adults, family member with a short QT interval, family history of sudden cardiac death. ECG shows QTC less than 350 millisecond with tall peaked T waves. Features of QT interval to increase as the heart rate slows. Digoxin produces a relatively shortening of QT interval, along with downward sloping ST segment depression in lateral leads that produces a reverse tick appearance, widespread T wave flattening and inversion, and multiple of arrhythmias like the ventricular ectopic, atrial tachycardia with block, sinus bradycardia, regularized atrial fibrillation, any type of the atrioventricular block, drug-induced QT prolongation, and torsades. In context of acute poisoning with QT prolonging agent, the risk of Torsades de Pointes is better described by absolute QT interval rather than the corrected QT interval. The more precisely, the risk of Torsades de Pointes is determined by considering both the absolute QT interval and simultaneous heart rate on the same ECG tracing. These values are then plotted on the QT nomogram to determine where the patient at the risk of the Torsades de Pointes or not. The QT nomogram is a clinically relevant risk assessment tool that predict arrhythmogenic risk for drug-induced QT prolongation that can be used for risk stratification. A QT interval and heart rate pair that plot above the line indicates the patient is at risk of Torsades de Pointes.